I'm fairly poor with a microphone, so I sometimes end up talking like this and forgetting to have the microphone. So if you can't hear me, let me know.
Sorry.
I have a presentation. Normally what I like to do is just talk about back pain, you know, when I first see a group, and just talk about back pain in general. It's common, it's costly, there's a million things that cause it, there's a million ways to treat it. It's very challenging to diagnose. So we have a couple of options today. I can bring my computer over here and kind of walk you through that. We won't be able to see anything on the screen. Or we can just start with questions. And oftentimes those questions will lead us where we normally end up anyways. I recognize a few faces in the room. Nice to see you. So it's up to you. I'll leave it up to you how you'd like to do this. I can give an informal presentation and tell you about the spine, generally speaking, you know, what composes the spine, what are the elements, or we can just start with questions and go from there. So, what's your preference?
Presentation would be my preference.
Okay, all right. So let's do this. What I'm going to do, since I don't have anything over here to show you, I'm just going to tell you a bit about the spine, and then we'll talk about spine pain. Does that work? All right. I have a couple of spine models here. You're welcome to pass these around, okay?
You want this to pass around too?
Yeah, sure. Actually, we use this to point at if that's okay.
Yep.
So, were I to strip away all the bits and pieces of every one of our bodies, this is what we'd be left with in terms of a spine. Here is your skull, okay? And then you've got a couple of dozen vertebrae going from the top to the bottom. So the top of our spine, there are 7 vertebrae called your cervical vertebra. The middle of your spine, there are 12 vertebrae called your thoracic vertebra. Those are the ones that hold the ribs. And then your lumbar spine typically has 5 vertebrae. Most of the time, when there's going to be a problem, it's down in the bottom. And the reason for that is the entire weight of your upper body goes right down through one place, the very bottom of your spine, and then all of that weight and pressure has to go over through your hips. So as we age, typically what's going to wear out is the bottom of your spine, and most of the problems we see are in the lumbar or the low spine. Secondarily, we see, you know, maybe for every 10 cases, let's say, of lumbar spine pain, maybe we'll see 2 or 3 of neck pain or cervical pain. It is really rare that we see people with problems in their mid-back and their spine because it's a really stable part of your spine. Your neck moves, your low back moves, your mid-back doesn't really move. It's held together by your rib cage. So it's pretty rare that you have problems with your mid-back or your thoracic spine. Can everybody hear me okay? All right. As we go, please, please, please ask questions, right? That's what we're here for. So, sorry. No worries.
The back break. Oh no. Uh-oh.
Did you lose a hip?
That's why we're here. So we're all here.
Yeah.
The back broke.
Oh no, yeah, we lost a hip. It happens all the time. So, yeah, so don't sweat it. So a couple of dozen vertebrae, which are these bones, okay, and they're separated by discs. The disc's job is to support your back. Those discs are shock absorbers. So if you ever had, you know, a bushing or a shock absorber or even a strut on your car, what they do is when you get jerked up and down, they soften that and they cushion it and they allow your spine to move. So it is normal for discs, which are oval, to bulge. So we hear this a lot, I've got bulging discs. That's wonderful, they're doing what they should do. Discs are supposed to bulge because that means they're absorbing the forces they're supposed to. But these discs can sometimes tear, and when they tear or they herniate out, that's when you can have pain. So, a couple of dozen vertebrae, each of them separated by a disc, an intervertebral disc. And then between the vertebra, if you look at that spine over there, on the left and the right, there's a hole. So you can see there's a little hole on each side formed by the vertebra. And out of those holes come nerves, okay? These are big spinal nerves that are responsible for your ability to move your arms and your legs. So for me to do this, for instance, the 6th cervical nerve, that 6th nerve up in the neck has to work. If it doesn't work, I can't do that. C5 doesn't work, I can't do that. So that's how we know. Sometimes you can herniate a disc and injure a nerve. You can have arthritis with significant narrowing around the nerve, but when you injure that nerve, you have pain that goes somewhere, right? It goes down your arm and your leg, and people often refer to it as sciatica. Sciatica is, everybody uses it for something different. I've got sciatica. I've got sciatica. I've got sciatica. So it's not really the true term, but it's something that we all use. Okay, so those nerves come out and they're responsible for our ability to move and feel our arms, and they can be injured as well. You have a spinal cord, okay? So your brain sits in a big old bucket of fluid, and that's your skull, okay? And so the brain's sitting up there and floating in that skull, and then at the bottom of the skull there's a big hole. So the brain connects to your spinal cord, and it goes down through that hole, and it goes all the way down your spinal column, okay? So you can get what's called spinal stenosis. You can get narrowing around that spinal cord as it goes down your back. Not everybody who has spinal stenosis is going to have pain or any problems at all. But when it gets really severe, it can cause back pain and leg pain. So we're just kind of walking through. Are these all terms some of you have heard? All right?
Many times.
I'm sorry?
Many times.
Many times, I'm sorry. Okay, so we've talked about the discs, we've talked about the vertebra, we've talked about the nerves. We have little joints in our back, and those little joints are what keep our back from shifting forward and backward. And we can't turn our spines like an owl, right? We can't rotate 180 or 360 degrees. Those joints keep us from doing that. But those joints, those little joints can get arthritis, just like a hip or a shoulder or a knee, and they can cause pain. Lastly, at the very bottom of your spine, where your tailbone meets your pelvis, tailbone is the sacrum, the pelvis is the iliacus. You can get sacroiliac pain. So that is a really, really broad brushstroke of the things that we're generally talking about when we're talking about back pain. And so now, having said that, 90% of the time, we're not entirely sure what's causing the back pain. 95 to 99% of the time, that back pain is going to go away on its own. Okay, so the hardest thing I do when I see a patient is really, I want to sit and listen to them and say, hey, tell me about your pain. Tell me how this is affecting you, what it's keeping you from doing. We want to make sure it's not bad, cancer, tumor, infection, fracture. Rarely is it any of those. And then we want to say, well, what could be causing it? And more often than not, it's probably not just one thing. Okay, so I can walk you through my presentation now and give you a bunch of numbers and diagnoses and things like that. They're better served with seeing some images. But let's start with who in here has had back pain? Me. Yeah. So 80% of people in their lifetime are going to have back pain. At any given time, 10% of the people walking the face of the earth have back pain. It is extraordinarily common. Right now in the US, at any given time, probably 25% of the people that you encounter are going to have back pain. So it's common. And it's not just here. Believe it or not, if you add up HIV, cancer, respiratory tract infections, malaria, and there's one other one. If you add all of those up in the world, they still do not cost the world and society as much as back pain does. So we spend about $700 billion a year on back pain in this country, which is basically what the Defense Department has for their budget. Right? If you think about it. And so part of that is what we spend diagnosing and treating it, and part of that is what we lose in terms of people's ability to contribute. They can't work, they can't support themselves, they can't support their families. So back pain is a really big problem. It's very common, it's very costly, and I've showed you just briefly the number of things that can cause it. And there are a gob of ways to treat it. Some of them effective, some of them not. Some of them costly, some of them not. We do about 700,000 spine surgeries a year in this country. It's pretty remarkable. Do we see that 700,000 people get better, go back to work, and their pain is gone? We don't. So what we really want to try to do is when you, I hope none of you have to come and see me, but our job really is to say, hey, tell me who you are. Tell me about your pain. And our job is to know what's going on elsewhere, medically, by looking through that chart, and then coming up with a plan and working from conservative to advanced to say, how do we help you get back to function? Right? There are times when you need to go directly to surgery. If you have severe neurologic damage, the vast majority of the time you don't need to. Only 2% of people ever need surgery. So 98 out of 100 people walking through that door aren't going to need surgery. But we need to work with you and use our team to help you get where you need to. And we've got a really great team. We've got excellent therapists. We partner with a neurosurgeon over at Valley View. Myself, I'm a physiatrist. I can tell you what that means. Most people don't know what it means. Anybody know what a physiatrist is?
Yeah, pain management.
Okay, there you go. Well, I didn't really know what it was until I finished medical school. Okay? So, after World War I, we had a whole bunch of soldiers come back from the war theater. They had brain injuries, they had amputations, they had burns, they had strokes, and we had no way of caring for them. So we had a field called physical medicine and rehabilitation, or physiatry, that was developed to help these soldiers, and really help them very specifically with their injuries. And so that's where it started. It has evolved over time. We still do that. People still do fellowships and all of those things. Brain, spinal cord injury, stroke, amputation. Children with cerebral palsy, children with spinal bifida, we help those children. But most people, like I do, go into managing spine and joint pain. So I did a 4-year fellowship at Mayo Clinic, and that's a typical duration for a physiatry or a residency, and then I did a year of an anesthesia-based pain fellowship to learn really specifically how to do some of these more advanced techniques. So for me, I like doing that. It gives me, I like being the person that can try and help somebody get out of pain. But it's only part of it, and ideally we do everything we can to keep from having to do injections or surgery. And that's therapy, medications, sometimes acupuncture, sometimes chiropractic. So there's lots of ways we can treat it. Anybody in here who's had back pain want to talk about it or tell me what they did about it?
Well, I guess.
Yeah.
Okay. I have cerebral palsy.
Okay.
And I've had it since I was 9 months old. So I've lived with pain all my life. And I've had 3 surgeries done on the lower part of my back by Dr. Miller and Dr. Crowd twice. And I'm still in a lot of pain, and I don't know how to get rid of it. So probably I need pain management, but
Yeah.
it just hurts so bad that right now it's hurting like crazy. So.
Okay. When did your pain start?
Where did my pain start?
When did it start? Where in your life? Was it when you were younger, or?
That was when I was 9 months old.
Okay. Yeah.
Because the doctor, I had a seizure in the doctor's office.
Okay.
And he said, get that child to the children's hospital. So they did some tests. I was 3 months old when that happened.
Okay.
And it took them 6 months to figure out what I had. And ever since, I've had surgeries on my legs, on my hands, on my back. If I hadn't had any of that, I would have been a lot worse.
It's a hard, without watching you walk, it's hard for me to say. Is it spastic diplegia? Is it both of your legs? Or is it, are your arms
Just my
involved?
right side.
Just your right side. Okay, yeah. Yeah, so that's it, right? We do things. Do you mind if I speak a little bit about cerebral palsy?
Oh, no.
Yeah, so this is something that, you know, we learn in residency, and then typically we kind of specialize. Some people specialize in that. I don't. But it's a really good example, right? With cerebral palsy, the brain, when we're young, and typically when we're in our mother, the brain forms in a certain way. And sometimes there can be an injury during childbirth, and sometimes it just happens. But for us to move, we have to get signals from the brain that go down through the spinal cord and the nerves. And if the brain and the spinal cord are not moving right, it makes it really hard, or working right, it makes it really hard to move, right? And so you end up with contractures. I didn't catch your name.
Deborah Trujillo.
Deborah, Dustin, nice to meet you. Would you mind, is it okay, do you mind holding up your arm there? Can I have people see that? Thank you.
You're getting tangled.
Yes, thank you. Thanks for showing us. So what happens is, and this happens, those muscles don't have the right signal from the nerves. And so if they don't have the right signal, they can't move. If they can't move over time, they get tight like this, and those muscles get really tight. So I suspect when you had surgeries when you were younger, it was probably a release of some of that tightness in your legs to allow you to walk or move better.
In fact, that doctor had to stretch the heel,
That's exactly it.
and I had to wear one of those braces that Forrest Gump used to wear. And it didn't do any good, so...
So it's an interesting thing. This is a primary problem with the brain, but we don't see the brain. We see where it happens here with the muscles, right? So if you herniate a disc, let's say, and you affect one of those spinal nerves that I've told you about, you can very similarly not have the right signal to the muscles and not be able to use them,
And
either
that's why
feel
the
them
head goes in.
or move them. So everything has to work. The brain has to work, it has to send the signal to the muscles, and the muscles have to be able to work. And if there's something along that pathway that is not working, it can cause you problems. And then, do you mind if I keep chatting a bit? Deborah, so the hard part is, right, they fixed those heel cords, they did the surgery, you're better, you're able to move, but now, over your entire life, you've been walking different and moving different. Our spines, as they've, evolved and changed over time, they really like balance. They like being straight up and down. They like it when you walk normally. So when you don't walk normally or move normally, you get more forces on the spine, and it can cause other types of pain. Back pain. You've seen Dr. Miller and Dr. Krauth. I've worked with them both.
And Dr. Krauth and Dr. Colbridge did my knees.
Yeah, you've had great surgeons. But that's the hard part, right? So we talked about the brain, the nerves, the muscles. What we didn't then talk about is the joints. So if all those things aren't in balance, you wear out joints, right? So it's all kind of tied together. We were talking about, if you don't mind, we were talking about your toe. It's pretty common that I see people that come in and they say, hey, I just had my ankle replaced, my knee, my hip replaced. Gosh, it's better. Now I got back pain. Or I got sciatica. And the hard part is what's happening, they're walking different, right? They're putting new forces on their spine. So this is one of the challenges of what we do. It really is sitting with you and say, tell me about when this started. Tell me about what's going on. I'm going to watch you walk and watch you move. And let's see if there's not something else that's going on here that's causing that problem.
And then when I get really, really tired, I start moving.
I'll talk your ear off. Anything you bring up, I'm going to talk to you.
That's okay, I was just saying that part.
No, this is really good, right? So
Yes, it is.
I'm somebody who has had a nerve injury multiple times in my leg, right? And I know what it is to have that pain and have that weakness. I know that nerves can heal and muscles can heal. And if I see you in my office, I can be like, I don't see that you have any weakness. When we get tired, and we get exhausted, that's oftentimes when we're going to see weakness, especially in the foot. We're going to hear somebody say, hey, I do great. Gosh, at the end of the day, I find myself catching my foot, or I find myself dragging my leg. So that's actually really common.
And it turns in.
Yes.
It turns into a fall.
Yeah, and that's it. That's the risk, right? So you're talking, you come and we talk about pain, and I say, gosh, you're at home, you've got rugs in your house, you're 87, you're on a blood thinner. If this causes you to fall and you break a hip, you've got a 50% chance of being dead in 6 months, never making it home. So that's back to that functional piece, right? When we talk to you, we say we want to help with your pain, but we also want to see how else this is affecting you to keep other things from happening. And I have that conversation a lot. I think, I check balance on everybody, whether you're 20 or 93. And if you're beyond about 60 and your balance is really poor, I'm going to say you need to get over to therapy. You're here for one thing. We do not want to fall. We do not want you to fall because of the risk of that, of death, or, you'll be in a skilled nursing facility for a long time and maybe never make it. Yeah. Oh, sorry. I apologize. Told you I'm horrible at my
Your mic stand.
Thank you.
He is one.
What other questions? What other types of pain have you had? Is anybody in here? Yeah, tell me.
What if it's not, it doesn't seem like it's all the time, but what if you just have lower back pain occasionally? Is there something you can do yourself? Or?
Yes, that's exactly it. And that is so common. Again, 80% of people are going to have just this sort of pain.
Yeah, and it's not all the time, but when it's there, you can feel it.
So there's some big things we say, right? What are the things we have control over? When it comes to pain, there are a lot of risk factors. Well, we can't choose our parents, right? We know that we inherit some risk, in particular for arthritis and other types of pain, so we can't do anything about that. We can't do anything about aging, so take that one off. Weight we can do something about. Every pound here is 8 to 10 pounds off the back, so even losing 5 pounds becomes 50 pounds of pressure off your back. And I often tell patients, your weight is not causing your pain, but it's certainly not helping it. Right?
No, it's a big part of it, I know that.
Yeah, so that's one thing.
I like to eat.
Yeah, I'm a realist. Look, hey, I'm a skinny guy, and I've got back pain, and I've told you that, right? So it's just one part of it. We know it's a risk factor, but it's not everything. Smoking is a huge risk factor for pain, and back pain in particular. Chewing tobacco and vaping as well. When you use tobacco, the vessels in your body, they kind of spasm or they quiver, okay? And you have tiny little blood vessels that go to your spine. They're really tiny, and these discs in your spine does not have a really good blood supply. So if you're smoking or using tobacco, those tiny little blood vessels do this, and the structures in your back don't get the blood supply that they need to, and they wear out faster. So it's so significant that if anybody in this room right now were to go get spinal surgery right now and need a fusion, the surgeon probably would not do that surgery if you were smoking. They would say you need to be tobacco-free for 6 weeks. Smoking, chewing, or vaping. So that's another thing. We're talking about the big things you can do. Weight loss, smoking is another thing. The other thing is just staying active. Okay, so has anybody ever worn one of these black lumbar belts or seen somebody at Home Depot wearing them? Okay, what they do is I'm going to try and do this. I need a third hand. Figure that one out, right? So here's your spine without any muscles. It's pretty floppy, okay? Those muscles in the front and the back of your spine are intended to protect your spine so that when you bend, twist, lift, jump, any of those things, those muscles serve as shock absorbers. They take the force off your spine. But if they're weak and deconditioned, even little things, those forces go directly on your spine and can cause worsening pain and degeneration. So why do those black belts work, right? What they do is they do what you want the muscles to do. They squeeze that spine and they support it. The problem is if you keep wearing those, your muscles no longer have to work. And we've got really good studies showing that people that wear them chronically, when they take them off, they actually end up with worse pain. So we know when you hear people talking about core strengthening and back strengthening, you kind of roll your eyes and say, all right, look, I'm tired of hearing that. But it is really important. It's really important to stay active, and it's really important to keep these muscles strong, because that's what protects your spine. Yeah.
I don't know if this adds anything or not, but I'm going to say it anyway. When I was doing clinical trials, one of the things that we did was to see if vitamin C would provide a buffer between, with the spinal and bones, etc.
Yeah.
Because the analogy or the theory was that when you smoke, I think it's carbon monoxide, I can't remember, but anyway, it knocks the oxygen molecule off of the red blood cell. And so they were trying to find a way to provide a buffer between that chemical and the red blood cell to keep the oxygen molecule where it belongs, you know, so it would go out to the rest of the body. Smoking is so detrimental to every single body part we have and chemical balance in our bloodstream that people really don't understand because they don't have the background of studying all of these different factors that have to do with your blood and how it feeds and nourishes your body. But the oxygen molecule being knocked off is a deprivation to your lungs. It's a deprivation to your bones. It's a deprivation to your muscles. It is just a killer. And so that's all I wanted to say.
I'm super impressed, by the way. Like, I should have had you take some of my boards for medical school. Like, no, and it really is. I mean, it really is impressive what you just said, because that's exactly it, right? It has these really harmful effects, and you'd say, well, why would anybody do that? It also happens to be the most addictive substance, even more so than fentanyl, heroin, OxyContin, cocaine. And the reason for that is it's social, right? You can't really go out and shoot up with your friends. People do it, right? You can't do smack or, you know, cocaine with your friends. You can't go smoke. And so much of what we do with smoking is linked to social activity. And that's what makes it really, really hard to quit.
And chewing has the same effects, except it adds on one more thing. A person who chews tobacco is taking a huge risk of developing oral cancer and lung cancer and vocal cancer. It's a destructive force that people don't understand because there's not much teaching that goes on in the community about that. And I suspect it's because fewer and fewer people chew. But those who do have a wad in their mouth all of the time.
Absolutely. Yeah, we think it's benign, but there is a risk there for sure.
It's a killer.
Did you have a question?
Yeah, I've had back pain almost all my life. And you were kind enough to do a nerve block on the lower part, which worked really well, by the way. But I'm back to having a lot of pain, especially in my mid-back right now. Mm-hmm. And I've also been, since I've seen you've been diagnosed with carpal tunnel. Mm-hmm. And now my feet and toes are numb. Mm-hmm. Is that a back thing, or is that something else?
It's a bad thing. It's a bad thing.
Thank you.
Back thing.
Yeah.
I know it's a bad thing. I'm saying back. B-A-C-K.
So I really try to be very cautious with HIPAA and acknowledge people as people in the community. If I've seen you before and I say hi and we don't talk about the fact that I've seen you as a patient, Don't take it personally. That's my job. It's me doing the right thing. I can tell you, as it relates to numbness and tingling in the hands, right? So I'm a very, like I gesticulate, I speak with my hands. So getting back to the brain, we talked about the brain. If you think about a tree has a root ball, right? It's got this big wad of roots right beneath the tree, and it's got a big trunk. All right, so let's use that analogy. Let's flip that tree upside down. You've got that big wad of roots, which is the brain. You've got the trunk going down, and then you've got limbs, big limbs, smaller limbs, twigs, and then tiny little bits of wood that get at the very end. Your nervous system is exactly the same way. So your spinal cord is maybe the size of your thumb. By the time the nerves get down to your fingers or your toes, they're so tiny, you can't really see them, lots of them, with your naked eye, right? You'd have to use a microscope, which is cool, right? You've got a ton of tiny little nerves that allow you to feel and hear really well and walk, but it makes them really vulnerable. So has anybody ever heard the term peripheral neuropathy or been diagnosed with it? All right, so peripheral just means away from, right? This would be central, peripheral would be way down there. And neuropathy is just a disorder of the nerves. So a disorder of the nerves that are way away from the body. 40% of the time we don't know what causes it, all right? But there are some risk factors for it. Alcoholism, syphilis, nutritional deficits, and as we age, B12 and folate, if our diet isn't great, we have a risk for that. The biggest risk factor in our society is diabetes. Okay, so we talked about tiny little nerves, and remember us talking about tiny little blood vessels? Tiny little blood vessels feed tiny little nerves, and in diabetes affects blood vessels. It affects the vessels in your eyes, in your kidneys, in your heart, which is why people have problems with those organs. But it also affects the little blood vessels that go to the little nerves. And so as those nerves don't get enough blood supply, they can die and be injured. And what that feels like, typically you'll see it in the feet first, because the feet are further away from the body than the hands. But as it progresses, sometimes you can get it in the hands. It's on both sides. Peripheral neuropathy is on both sides. It starts in the toes, and then it starts over time to progress up the leg in kind of a stalking, distribution. It can feel like you're wearing socks when you're not. It can feel like there's socks wadded up beneath your toes. It can be very, very painful. It can feel like you've just put really cold feet in really hot water. All of those. So sensory neuropathy, those are the sensory nerves, but you can also have a motor where you get weakness associated with that. So when you talk about numbness and tingling in hands and feet, then we say, hey gosh, peripheral neuropathy may be more likely than something with your back, right? So we also have to think about that neuropathy. Certainly you could have a problem with your brain, your spinal cord up here, but usually when you have numbness and tingling in your hands and feet, you start thinking neuropathy. There's a lot of things though, just speak broad brushstrokes. If you just have numbness and tingling down one leg or part of one leg, then you start thinking the back, right? If you have pain going down one leg, you start thinking the back. If you have pain going down both legs with some numbness and tingling, then you start thinking spinal stenosis, something a little further up of the spinal cord. So it's hard to answer that question specifically, but if you were to come see me, that's the conversation we'd have. I'd say, tell me about it. Where is it? Where's the numbness and tingling? We'd examine you, check your sensation and your strength, and then we'd put our heads together and say, all right, what could this be?
So does any of that have to do with like chiropractic? If my spine's out of whack or something, would that fix any of that?
So when you talk about if it's truly peripheral neuropathy, chiropractor, let me preface this. I don't know everything, I never will. The book of what we know about the body is about this high. The book of what we don't know is, stories high. So I don't know everything. I have my bag of tools and my training, and that's really, I try to speak honestly about that. So from what I know of chiropractic intervention, is it likely to have a significant benefit, that is manipulation, on a peripheral neuropathy? No. Does it mean it won't? I don't know. I think the risk is low. I think what I tell patients when they come in and they say, hey, I'm doing this, or chiropractor, I'm doing that, as long as it's not hurting you physically or financially, I don't have a problem with it. Again, I don't know everything. And that financial piece is important, because if somebody says, I can fix you, you have to come 5 times a week for the rest of your life, I'm going to say that's crap, right? Like that's, right. So that financial piece is kind of important as well. But chiropractic has a role. There are people that find benefit from it. It's not my training or expertise, but if it's helping you and it's not hurting you, you're not going to hear me argue.
Well, I used to go, when we lived on the Denver side, I used to go and get chiropractic adjustments and massages and stuff like that, because I had falls, 2 falls when I was 11 and younger. And my mom was a nurse, and she used to tell me that if you're younger, you know, like that age and younger, your spine is not exactly where, you know, to the point where it should be. And so naturally, I would fall twice when I was below 11 years old. So I don't know if I think one time I broke my tailbone and she never took me to the doctor, so I don't know that for sure. But I couldn't sit down for a week.
Eesh.
And that was a fall from a horse. Landed smack on my keister. And then the other one, I don't remember, but she said I was trying to reach for something on the top of the refrigerator. I was on a bench, and I fell from the bench. And I was probably 5 or something, or younger. So I don't know, but I've not had a good back since then, and I just feel like with all the other things going on, that things are just getting higher and higher on the pain level.
Yeah, it's a challenge, and you know, toward that end, so we have a nerve pain system. We're really complex. The brain is like it's the final frontier. There's so much we don't know about it.
It's like space.
It is. No, it really is. I mean, look, we're growing organs in test tubes, right? We still don't have the brain figured out. What we're doing in pain medicine, we've been doing that for 50 years. We haven't really changed what I do significantly. But the brain has such a big role in everything. And when you talk about chronic pain, if I were to do this, you know, and just tap on my muscle, just like that regularly for a year, probably 6 months, and if I stopped doing that, the brain would likely continue to perceive that.
Yeah.
And what it's done is laid down pain pathways. So when you were younger, probably most people learned how to ride a bike. You cannot ride a bike for 20 years. And within reason, you could probably still get back on that bike, right? Maybe a little wobbly, but you'd have some memory of it. Well, the body and the brain and the nervous system remembers pain. So that once you have these chronic pain pathways set up, even if you take away what has caused that pain, you may be left with a pain syndrome. And that's what makes treating chronic pain much more difficult, is you now have these pain pathways laid down. And we see this with people with amputations, right? Phantom limb syndrome. You can have a knee or a leg amputated, and you can still feel that and have extraordinary pain. And so that's part of the challenge with chronic pain.
So having all of that done before I moved over here, and then I haven't been to either for quite some time, does that adversely affect things too?
I wouldn't say it does. I think unless there's really clear, this happened and my pain started immediately, I'm always pretty cautious with saying, you know, really giving a cause and effect. Does anybody here have fibromyalgia? Does anybody know anybody with fibromyalgia? Yeah. All right.
You name it, I have it.
Okay. Well, fibromyalgia used to be this, back in the 80s, it was kind of this wastebasket term. And I mean that because it really was, you'd come in and you'd kind of have pain everywhere, and your doctor would say, you've got fibromyalgia, get out of my office, right? And there wasn't really any basis. There wasn't really any basis for that, but there is really good data behind it. And so for 20 years now, the American College of Rheumatology has really specific criteria for diagnosing fibromyalgia. It is a very real diagnosis, and it can be very debilitating. And what happens with fibromyalgia, getting back to the pain system, if you imagine somebody has a normal pain threshold and pain system, that all gets ramped up, right? All those neurochemicals, the neurotransmitters, the pain pathways, they get really amplified, and we don't know what causes it. And so that when somebody with fibromyalgia has pain, it's more intense, it lasts longer, and it's more debilitating. And it's a diagnosis of exclusion. We don't have a test for it. We do not have a test for it. We have criteria for how long it's been there, how it affects you in terms of sleep and fatigue and those sorts of things. But we don't have a test for it. We rule out all the other things, thyroid abnormalities, all the other things that could cause it. But it's there, and it's real, and it can be debilitating. And so I'm bringing that up because, not dissimilar to chronic pain, fibromyalgia is a chronic pain syndrome. Once you have it, it typically doesn't go away. It makes diagnosing and treating other pains more challenging, because now you're trying to do this on top of this other pain syndrome. So it really is looking at all of those things and trying to say, how can we reasonably and safely help somebody? Yeah.
Oh, okay. I just was glad that you mentioned vaping and the fact that they wouldn't do surgery if somebody had that. I have about 6 grandkids in their 20s that think that's just wonderful, and they don't look, they're just living for now. They don't see down the road what it's going to do medically.
Yeah, no, there's plenty of, look, you're trading worse for less worse, or bad for less bad. You're still trading one addictive substance, maybe with less chemicals, you know, from the other.
Yeah, I know. I went to the seminar that they had at the hospital on vaping. Oh my, you know, it's like, but, you know.
Yeah, no, I mean,
They say, it's okay, Grandma, and I don't say nothing to them. They're old enough they can figure it out, but they know that I think I wish they would quit.
yeah, well, and I think in some respects it is more socially acceptable, right? So you can't smoke in a lot of places in Colorado and elsewhere. Yeah, but you can vape, right? So it's this in between, and it's a challenge for sure. Yeah. What else? What other questions? I have really smart people in this room, so thank you. Yeah.
With my spinal implant that I was, prior to that, I was thinking, I'm going to have to make them go back in and remove the fusion to go back in and do what they should have done in the first place. It was, and I was either that or I was going to have to spend the rest of my life on a bed. And so Dr. Whitwer put in the implant, and just recently, continue to have really bad pain. But when I was feeling so much better that down the road I began to think, well, this isn't doing anything anyway. And I got careless about charging my battery. And so all of a sudden, well, not all of a sudden, just gradually, I was back to where I think I'm going to have to spend the rest of my life in the bed. And then I thought, how long has it been since you charged your battery? And it had been a long time because I had to charge the battery that charges the battery. And so when I went through all of that process, again, having myself charged up really good, I began to have less pain again.
Wonderful.
And I was being able to turn down on my remote control how much charging I was having to do.
That's fantastic.
So now I have finally found a balance, and I'm really uncomfortable all the time, but there's a difference between being severely uncomfortable and I can't walk anymore.
Yeah, do you mind if I explain how that technology works?
Please.
Okay. So, and I'm just going to, again, I'm going to be very cautious with HIPAA. I'm going to talk in general here. There's something called a spinal cord stimulator, or neurostimulation. And so, has anybody ever smashed their thumb with a hammer or something else? Yeah, 100%, right? If you're me, the first thing you do is cuss. But typically, the second thing you do is you grab that thumb, and somehow it feels better, right? What's going on there? There were these guys back in the 60s called Melzack and Wall, super smart guys. And they developed something called the gate control theory of pain. And what it means is, in your body, you have pain, temperature, touch, vibration receptors, all these different types of receptors. When you smash that thumb, it's those pain receptors, and they hurt like heck. When you do this, you stimulate the pressure receptors. The pressure receptors override the pain receptors, and they scramble that pain signal. Which way, it's like, it feels better. Ow! Back on, right? And you do that, and you kind of hold on to it until it goes away. With a spinal cord stimulator, we've talked about the spinal cord. The spinal cord sits in a column of fluid, the spinal canal. The area around that spinal canal, all the way up, is called the epidural space. It's filled with fat, right? So it's on the outside of that column of fluid. You can put electrodes in that epidural space. And so there are two wires like this. There's other versions as well, but typically two wires. They have little electrodes and they talk to each other. And you can program them with the computer, and there's 5 million ways to program them. But they scramble the pain signal. So when the pain signal is coming from your legs or your back or your arm, it has to come through those nerves back up through the spinal cord. And right when it goes through that area of the spinal cord, those electrodes are scrambling the signal in the same way you manually scrambled the signal here. Does that make sense? Mm-hmm. So we use those spinal cord stimulators typically for pain in the legs or the arms. It works better for nerve pain. It doesn't work as well for just back or neck pain, although it's getting better. And we use it when everything else hasn't worked. Surgery hasn't worked, you're not a surgical candidate, injections haven't worked, medications aren't helping. It really is something we do as a last resort for really debilitating pain. So what you do when you go, and I used to do these, I don't anymore, I'm not busy enough here at the hospital in that respect. Somebody comes in, they lay on a table in the OR, you do an epidural injection like you would normally, and then you push these wires up behind the spinal cord, you use an x-ray to see where they are, and you program it. And somebody's laying on the table and you say, can you feel that? Can you feel that? Is it capturing your pain? Once you get there and everything looks good, you just tape those wires to the back. And then you have a battery generator that you tape to the back, and you go test drive it for 3 days or a week. And you walk around and say, does it help? So if at the end of it, it doesn't help, well, you're done. You pull the wires out, you're good. If it does help, then you go and do that permanently. You put those wires in there, and then you bury those wires underneath the skin, and you put a battery right under the skin and the butt, not where you sit, because that's really uncomfortable, but you put it over here, and that's how you charge the battery. So you have a rechargeable battery in your butt that feeds, and it's got a little generator, a little computer that scrambles the pain signal. So the battery has to be charged, and you have to program it. But it is an interesting technology, and it's pretty safe, and it can really be life-changing.
Two screws in it. I had back surgery 20 years ago, and the screws are, she said it feels like a $7. But she gets back pain quite a bit. Is that something that might help her, or would you feel they have?
So the first thing I would do, if there's a concern that you have screws that are loosening or coming out, you get x-rays, and if it's not obvious on those x-rays, you can then do a CT, which will show you that better. So if there's no hardware loosening, you're going to do this, and you're going to say, that's relief, we don't need to redo the surgery. But then you're going to say, dang, we've got to figure out what else is causing it. So usually for back surgery, what we call failed back surgery, when it didn't help, that spinal cord stimulator works better when you've got nerve pain down in the legs. It doesn't work as well when you've got pain just in your back. But there's a lot that goes into that decision. But the first thing you want to do is make sure that hardware looks good and it hasn't broken and there's no loosening. Yeah, and you do that with x-rays and sometimes a CT. Yeah, TENS unit works the same way. So a TENS unit does on the outside what a spinal cord stimulator does on the inside. Yeah. So, thank you. Ashley's given me the go-ahead. I really enjoyed this. I appreciate getting to talk to you. I'm sorry I didn't have that presentation ready, but I really appreciate the questions. I think sometimes that's as valuable because you get your own questions answered instead of me just kind of blathering about what I think is important, which I kind of did anyway. Yeah.
Good speaker.
Again, we have a great team at the hospital. You have myself, an interventional pain specialist,